Good morning, good evening, or good afternoon, depending on where you are. It's with great pleasure that I welcome you here today for this webinar on optoacoustic imaging for disease monitoring. My name is Neil Burton. I'm the CSO of Ithera Medical, and I'll be moderating this session. So today we have three speakers, Dr. Hailong He, Dr. Sara di Giulio, and Dr. Dinish U. Dr. Hailong He will present first, followed by Sara, and then followed by Dinish, and the question and answer session will follow the last session. Hailong received his PhD at the Faculty of Electrical Engineering, Technical University of Munich. Afterwards, he worked as a postdoc researcher at the Institute of Biological and Medical Imaging, or IBMI, at the Helmholtz Center in Munich. And since 2021, he works as a group leader at IBMI, and his research interests include the development of optoacoustic imaging techniques for clinical applications. So, Dr. He, over to you.
Yeah, great. Thanks a lot, Neil. Thanks for this very kind introduction. I'm very happy to have this opportunity to introduce my work today. So today I'm going to present some recent developments about skin microvascular complication in patients with diabetes using optoacoustic mesoscopy. This project is founded under the European grant WINTER. So WINTER, let me first briefly introduce WINTER project. WINTER is a EU-funded project under the Horizontal 2020 program. It brings together the expertise of small and medium-sized enterprise and academic partners in the field of optoacoustic imaging. Optoacoustic imaging, or photoacoustic imaging, has dramatically improved the conventional penetration depth limit of a microscope and enables three-dimensional high-resolution imaging inside deep tissue of skin. Previous research under the program of Endoderm had demonstrated raster scanning of the optoacoustic mesoscopy can image previously invisible pathophysiological, oxygenation, and morphological features of the skin at depths of 1 to 5 millimeters. So WINTER builds on this success. WINTER brings a new capability aimed to improve the clinical accuracy of RSOM and enable new possibility in therapeutic monitoring of cardiometabolic disease and inflammatory skin conditions. And this project is driven by multiple partners, leading by Technical University of Munich and also the industry partner Ithera Medical. And now I'm going to come to the outline of my presentation today. So I will first introduce some the basics of RSOM, and then give you talking about the machine learning based image analysis pipeline, which we use to analyze the RSOM dataset. And the third part, I will introduce a clinical study which applies RSOM to assess the microvascular complication in patients with diabetes and associate the disease severity with RSOM image features. So we define the mesoscopy as a gap bridge high-resolution microscopy and a macroscopy with deep penetration depths. So optoacoustic mesoscopy is designed to achieve a resolution in tens of microns with a tissue penetration depth of a millimeter range. So it has a bit lower resolution compared to the conventional optical microscopy, but achieve much deeper penetration depths than microscopy. And the mesoscopy is suitable to image the small organs or superficial tissue, such as human skin. As the largest organ of human body, skin has a layer structure, including a superficial epidermis and dermis layers. The human skin thickness varies from hundreds of microns up to a few millimeters, depending on the locations. In the dermis layers, it contains a rich vasculature with a diameter ranging from tens of capillary to more than 100 micrometer diameter. So to fully assess the skin structure, it requires imaging modality that provides tens of micrometer resolution with several millimeter penetration depths, which exactly following the scope of the optoacoustic mesoscopy. Raster scanning of the optoacoustic mesoscopy has shown the superior capability to image microvasculature at a resolution of tens of microns through the whole skin depths by combining optical excitation with ultra-broadband with ultrasound transducers. Here I introduced the faster RSOM system based on a highly sensitive ultrasound detector and top coaxial illumination scheme implemented by a transmit light using a single fiber through a central aperture of the high sensitivity ultrasound detector. This hardware innovations enables the use of a lower energy laser source at a higher repetition rate, affording a significant increase in scanning time without sacrificing image quality or exceeding laser safety limits. With this new implementation, the capillaries in the nail folds regions were nicely resolved, as shown in the image in the first row. The small structures correspond to the high frequency content, and large structures related to the low frequency were coded into green and red, respectively. Besides structure imaging, the molecular information, such as oxy, deoxyhemoglobin, melanin in the skin, were well resolved and visualized by using multi-wavelength RSOM. Here, we apply 4 wavelengths. You can separate the 3 chromophores. By removing the melanin signal in the right column, you can clearly notice the melanin distribution in the human skin. The 2 videos shows the volumes acquired using RSOM from healthy volunteer skin and nervous from a volunteer. In order to apply RSOM from clinical application, it is necessary to develop a reliable method that can automatically analyze RSOM volumes and compute the features. So we developed a machine learning-based framework, deep learning RSOM analysis pipeline, so-called DeepRAP, to analyze and quantify morphological skin features recorded by RSOM and extract imaging biomarkers for disease characterization. DeepRAP uses a multi-network segmentation strategy based on convolutional neural network with transfer learning. This strategy enabled automatic recognition of skin layers and subsequent segment of the dermal microvasculature with accuracy equivalent to human assessment. So DeepRAP encompasses 3 major technical development. First is a UNet-based model to separate skin morphology into epidermis and dermis layer, so we can compute the epidermis thickness. Secondly, a topological preserving loss function to train a deep vessel net, allowing for accurate segmentation of the dermis microvasculature in 3D. And then afterwards, we can automatically compute the skin-related morphological and vascular biomarkers, such as the vessel diameter, vessel length, the numbers. And to preserve the fine features, the DeepRAP processes the high and low frequency signal of the RSOM data separately, significantly improving the segmentation accuracy of the high resolution skin structure. Here shows the example of how from the original volume to the segmented volume. The second one, you can see the 2 colors indicate the epidermis and dermis, and then the third column shows the different color indicate the different diameter of the vasculature segmented. The video show example of the second RSOM volume, and also the 3D volume. So all the analysis were performed in the 3D volume. And then the segment comparison of the various RSOM data between the DeepRAP and the conventional thresholding-based method are shown in these images. The first column depicts the arranged RSOM volumes with strong reflection artifacts marked by white arrows, which appears in the region above the skin surface of the lower dermis mixed with the vasculature. Since the contrast of the reflection artifacts is similar to the RSOM features, the threshold approach cannot separate these artifacts well, they cannot completely removed. But with the DeepRAP method, we can easily separate these artifacts as shown in the 3rd column. In addition, the fine microvasculature normally has a less contrast or lower contrast compared to the large RSOM structure, which can be easily degraded using the thresholding segmentation approach. However, those fine microvascular features are well segmented in the DeepRAP image, indicate that this DeepRAP method can achieve much higher segmentation accuracy with RSOM dataset containing various contrasts and artifacts compared to the conventional approach. To demonstrate the superior capability of this DeepRAP, we actually apply the method to a group of RSOM volumes with varied image contrast. We record the 3D images of the skin structure during a 9 minutes cuff occlusion process. So this process containing 2 minutes baseline measurement without the cuff pressure, 4 minutes of cuff inflation, then we block artery, and then 3 minutes after the deflation. So cross-section images show that during the hyperemia process, there was a decrease in image intensity in the dermis compared to the baseline. Following the cuff deflation, we observe the vascular structure fully recovered with dilated vessel diameter and a more cutaneous vessel appeared. It is worth noting that the skin microvasculature was accurately segmented despite this strong variation in image contrast during this hyperemia process. In addition, the microvascular change during the hyperemia were characterized by computing the mean RSOM image intensity. We apply this DeepRAP approach to measure the epidermal length and the small and large vessel diameter, and the length and the vessel numbers. Those are all correlated to the image intensity. So to really capture this dynamic process and computer-related features for the quantification. Now, I will introduce a clinical study with the Winter project. So assessing the skin microvascular complication in patients with diabetes. As you know, there's a huge population of people with diabetes worldwide, leading to a severe healthy complication and aggregating the health costs. Diabetic cause macro and microvascular complications in different organs like kidney, retina, and skin. There are a lot of studies investigating the retinal microvascular complication using optical technologies. Actually, literature also suggested that the assessment of the skin microvasculature could enable novel means for monitoring diabetes and the progression of associated vascular complications. So using optoacoustic mesoscopy, RSOM is an ideal tool for this study. In this study, actually, we recorded RSOM volumes of the lower extremity from 95 participants with diabetes and 48 volunteers without diabetes, where the characteristics of those study participants are listed in this table. All participants were split into 3 major groups based on the presence of the relevant complications, such as peripheral neuropathy and macrovascular atherosclerosis and peripheral artery disease. So we have a group A consists of 45 patients without complications, neither neuropathy nor this atherosclerosis. Group B included 25 participants with neuropathy, but without atherosclerosis. Group C consists of 25 participants with neuropathy and atherosclerosis and peripheral artery disease. So 3-dimensional RSOM image were reconstructed over the 2 frequency bands. Here I introduce how we do the data analysis of this study. So we selected to reconstruct the image with 2 bandwidths. The lower bandwidth is in the range of 20 to 40 megahertz, corresponding to the larger vessels in the diameter range of above 40 micron to more than 100 micron. And then we also have a small bandwidth, the high frequency bandwidth from 40 to 120 megahertz, which corresponding to the small vessels in the diameter range less than 40 micron. So vessels seen in the 2 different bands are color coded in the images. The red corresponding to the large vessel, green corresponding to the small vessel. And quantification, including the computation of the vessel number and diameter, are computed based on the segment images. So we actually compute the 6 features from the RSOM volume, like the total number of the small vessel with a diameter less than 40 micron, total number of a large vessel with a diameter larger than 40 micron, and the vessel number and blood volume, the epidermal thickness, and the signal density in the epidermal layer. Here we first analyze how the RSOM skin images of the lower extremity between these 95 patients with diabetes and 48 volunteers without diabetes. So here shows the images of the skin, visually examine the difference between a healthy volunteer and the participant with diabetes. The left column image shows an image from a volunteer without diabetes, while the right ones show the corresponding image from a volunteer for a participant with diabetes. The images are rendered as a maximum intensity projection of the entire volume scanned and depict the epidermal and dermal layers, which the typical RSOM appearance of the healthy volunteer showed dense signal from the epidermis layer and a vascular network in the dermal layer that comprise several blood vessels of various diameters. Conversely, the dermal vessels density is far lower in the participant with diabetes compared to the healthy volunteer. Due to the loss of the fine dermal vasculature, the diabetic skin experience a characteristic high contrast boundary between the epidermal and dermal layers that's not present in the healthy skin. Furthermore, the 6 features we computed show significant difference between the healthy and the participant with diabetes groups. We next investigate the relationship between the peripheral diabetic neuropathy, a very important diabetic complication, and the microvascular features via the extracted RSOM label-free biomarkers. We first examined RSOM features obtained from measurement of the patient with diabetes without complication and measurement from participants with diabetes and different severity of a neuropathy. The severity of a diabetic neuropathy was clinically evaluated using the neuropathy disability score and the neuropathy symptom score. So we divide the diabetic group into 3 categories. The one group, those with no complication, those with a lower neuropathy score, and those with a high score of a neuropathy. Overall, the small vessels demonstrate a statistically significant difference between the 3 diabetic groups. And the computation of the blood volume also demonstrates a similar trend. So there shows that by monitoring the skin microvasculature, it can separate or classify the severity of the diabetic neuropathy. We're also interested in exploring the association between RSOM features and the macrovascular atherosclerosis. So most of the diabetic subjects with atherosclerosis enrolled in this study had also been diagnosed with neuropathy. Therefore, participants with diabetes were divided into 2 groups. So diabetic subjects with neuropathy and no atherosclerosis, and diabetic subjects with neuropathy and atherosclerosis. There was significant difference in the number of the small and large vessels between the 2 groups. And this also shows that by monitoring or quantifying the vascular, it can correlate the severity of the diabetic complication. Overall, these findings demonstrate the promise of RSOM as a potential point-of-care device for quantifying systematic complication with diabetics and providing a quantitative score indicating a disease stage. Okay, then I've come to the end of my presentation. I would like to acknowledge my institute, my group members and collaborators, and the funding source, especially the Winter Project. Thank you very much for your attention. I'm going to be happy to take questions afterwards.
Okay, thank you. Brilliant, Dr. He. I really appreciate it. It was a great talk. I'm going to take back the controls for the webinar and then hand those over to the next speaker, which I hope I'm doing now. I think so. Good. And we already have some good questions coming in, but I'll save those, as Hailong just said, for the Q&A session at the end. Having said that, though, if you do want to put in speakers, don't forget you can type these in. But I'd like to introduce our second speaker, Dr. Sara di Giulio. She obtained her MD with top honors cum laude from the School of Medicine and Surgery at the University of Parma in January of 2023. She's been serving as a substitute general practitioner in Parma since March 2023. Additionally, since February of 2023, she's been a member of the Italian National Board of Medicine and Surgery and the Board of Parma. Since November of 2023, she's been pursuing her residency in dermatology at Humanitas Research Hospital in Rossano. So, Sara, over to you. You're now the presenter. We see your slides, and I'm looking forward. Thank you.
Good morning, everyone. Thank you for introducing me. Today, I'm very glad to be there with Dr. Mario Valenti to discuss about the Winter Project. The Winter Project is a project, as I just said, Dr. Hailong, about the fast optoacoustic mesoscopy, a new technique that uses the skin as a window for therapeutic monitoring of local and systemic disease. In particular, our role in this study concerned the validation of experimental protocols, the validation of the acquisition technique, and the quantification of its power in the monitoring of some disease like immunorelated disease, but also actinic keratosis or cardiometabolic disease. More specifically, our objectives involves the validation of this technique through experimental measurements, the obtaining of the ethical protocol both for animal and human study, and the conducting of studies in human for monitoring therapy in cardiometabolic disease and skin inflammatory condition. At the last, we have also to define a portfolio of its therapy monitoring capabilities in collaboration with the Winter Project 4. Our defined tasks are 4, and all of these tasks are on track. The first task is the task 5.1 and concern the ethics commit approval by the drafting of a protocol both for human and animal studies, and we received this approval on November 50, 2022. The second task, task 5.2, involves the validation of Larson performance in phantoms and small number of animals. In this phase of our study, biologists had to study the epigenetic role of two genes, UHRF1 and G9A, as therapeutic target in the hair failure. In particular, it seems that these two genes are an active role in the developing of the hair failure in presence of some ischemic factor. At the beginning, they had to mate animal to create the colony with the proper genotype, and in particular, they collected two groups, a wild type group for UHRF1 and a second group mutated for the same gene. As we can see from the result, the two groups of animals had a similar echocardiographic parameters in basic condition, in absence of condition promoting ischemia. And this is the same after basic surgery, but after a specific procedure named transaortic constriction, some of these parameters are really worse in the mutated group than in the wild type group. This result had a perspective on Larson analysis that we had conducted in our unit. And we can see in this image the microvascular flow in the mutated group at an irregular pattern. The first task, task 5.3, concerned the studies in humans. In this phase, some of our dermatologists had to validate the acquisition technique before in healthy control and after in patient affected by cardiometabolic disease. We can see some image that we had took in healthy control, and in this slide some image that we have took in patient affected by some of cardiometabolic disease like hypertension, type 2 diabetes mellitus, and heart failure. The first task, task 5.4, is about the validation Larson vivo for therapy evaluation. We decide to analyze the Larson performance in two types of patients affected by actinic keratosis treated with topicals, and also patient affected by immunorelated condition like psoriasis and atopic dermatitis with or no cardiometabolic disease. So we took some image at the baseline and after the beginning of the treatment in these two situations. The first clinical case is about a patient affected by actinic keratosis. The actinic keratosis, named also solar keratosis, is a condition caused by an abnormal keratinocyte proliferation in the epidermis, and it could lead in some cases to squamous cell carcinoma. For this reason, we had to treat it. The first clinical case about the small patient of 84 years old that had cutaneous lesion on his left hand, and we took some image at the week 0 before the beginning of the treatment, and after 4 weeks of treatment that we decided to get with the diclofenac. The second clinical case is about a mole patient of 60 years old that had a history of psoriasis since 2018, affected also by arterial hypertension and hypercholesterolemia. In this patient, we took some image at the week 0 and the week 12 of treatment. In particular, we decided to begin treatment with anti-IL-23 biologic drug specific for this pathology. We can see the acquisition at the week 0 at the baseline, and in this case we took some image not only at the lesional skin but also at the perilesional skin. After 12 weeks of treatment, we took some image, and this is the change that we can observe at the Larson acquisition. The first clinical case about a male patient of 78 years old affected by psoriasis and psoriatic arthritis since 2011 that had also some cardiovascular, cardiometabolic comorbidities. Also in this case, we made the acquisition at the baseline, on a psoriasis plaque on the right knee of the patient. And after that, we decided to begin a treatment with ixekizumab. At today, we don't have yet the image of the follow-up because the patient will back in visit in the next weeks. At the last, we also study the RSOM acquisition in patients affected by concomitant arterial hypertension, dyslipidemia, and heart failure. And also in this case, the follow-up visit and acquisition are upcoming to monitor the effect of cardiometabolic therapy. The results that we had exposed are also discussed the last year at the ADV on Berlin, where we explain how this new non-invasive technique could have a great potential to improve the diagnosis, treatment planning, and monitoring of patients affected by immunorelated conditions. In this patient, often there are also cardiovascular disorder and cardiometabolic comorbidities, and for this reason, for us dermatologists, this new tool could be really useful to avoid the needing of further specialist evaluation. We also made a flyer that we had left to patients enrolled in our study to explain them what is RSOM and how does it work and what is its power and its potential in the monitoring of their pathologies. Thank you for the attention, and I'm there if there are some questions.
Very nice. Thank you very much, Dr. Di Giulio. It was an excellent talk, and I'll, just like before, take the controls and pass them on to the next speaker. Very good. Okay, great. Yeah, so last but not least, Dr. Dinish U will present. He received his PhD in biophotonics from Nanyang Technical University in Singapore. Currently, he serves as a group leader in the Translational Biophotonics Lab, A-STAR Skin Research Labs, A-STAR Singapore. Additionally, he holds a joint adjunct faculty position at the School of Physical and Mathematical Sciences, Nanyang Technical University in Singapore. Dinish possesses extensive expertise in the development of biophotonic technologies encompassing photoacoustic imaging, diffuse reflectance spectroscopy, Raman spectroscopy, surface-enhanced Raman scattering, fluorescence imaging, and multimodal imaging techniques for diverse preclinical and clinical studies. Notably, Dinish has been actively involved in pioneering first-in-human clinical studies that employ optoacoustic imaging for diagnosing skin cancer and inflammatory conditions. That being said, I'll turn it over to you, Dinish. And again, I'm looking forward. Dinish, you're muted. This could be because I muted you earlier.
Can you hear me?
Yes, we can hear you now.
Okay, yeah, thank you. Can you see my slides, right?
Absolutely.
Okay, thank you. Good afternoon, good morning, depending upon the geographical location. I would like to thank ITRA Medical and team for organizing this excellent webinar. Today, I will be giving a highlight of our advancement in clinical skin study using raster scanning optoacoustic mesoscopy, or in short RSOM, for inflammatory skin condition, specifically eczema and psoriasis. So just to give a quick overview of our institute is A-STAR Skin Research Lab. It's a part of Skin Research Institute, Singapore. A-STAR is conducting high-impact interdisciplinary skin research that translates to innovation and improved skin health for economic and societal impact. The key research activity is in A-STAR is split into 4 pillars, which is in skin aging and pigmentation, inflammatory skin diseases, skin microbiome, and wound care or tissue integrity. So our lab, specifically Biophotonics Lab, is developing photoacoustic imaging diffuse optical spectroscopy and imaging, Raman and surface and Raman spectroscopy for various applications of national importance in women's health, skin health, and vascular health. In this today's talk, I'll be concentrating on our skin health research activity, specifically using RSOM for inflammatory skin diseases. Our lab set up a joint industry lab with Ithara Medical few years ago, mainly to translate various photoacoustic imaging technologies, specifically MSOT, it's a tomographic technology, and raster scanning optoacoustic mesoscopy, which is high resolution imaging for skin for various applications in skin and other vascular conditions. I think Hailong and Sara already explained the basics of RSOM technology and its features, like in terms of resolution, penetration depth, and field of view. In this study, we use this system, multispectral system, which have a 4 wavelength at 532, 555, 576, and 606 nanometer. Thereby, we can unmix this tissue chromophores. So, since our focus is on skin inflammatory conditions are basically immune to response, environmental, and genetic factors. So, here, what are the difference or features this psoriasis and eczema? So this skin condition is mainly it's most prevalent in the body or most of the part of the body, especially in kids. That is mainly affected in the head region, and this affecting of the psoriasis is depending upon the severity, and accordingly it will be prolonged in the different part of the body. So when we look at the different characteristics of this skin inflammatory condition, one is erythema, that is basically the reddening of the skin, which is due to increased blood flow. Then inflammation, that is mainly due to the protective response of the body. Then is due to the itching, due to the dryness of the skin. Then epidermal barrier damage, which is caused by the damage of corneoid envelope in the stratum corneum. And of course, the scaling, which is a peeling of the skin due to the dry epidermal layer. So if you look at the disease prevalence, globally, atopic dermatitis or eczema is about 10 to 25% of the people affecting, and psoriasis about 11% of the people. But in Singapore, eczema or AD is very common. About 30% of the people are affected with this eczema at some point of their life. In children, 1 among the 4 children are affected by AD, and 1 about 9 adults are affected by AD. In psoriasis, the occurrence is about 1 to 2%. This causes a huge patient burden. It causes a huge load to our clinicians and as well as to the patients. So currently, these inflammatory conditions are assessed using a scoring system, which we call it as SCORAD for eczema and PASI for psoriasis. These scoring systems are based on some questionnaires and also observation by the clinician. The limitation is that it is a subjective system, subjective scoring system. Subjective means I am referring to it can be varied based on the inter and interpersonal variation. That means depending upon the observation and also based on the scoring system. And since it's a subjective system, it failed to give a quantitative information about the treatment response. It also gives a way to quantify and monitor the detection in the subclinical skin structural features. And it also fails to give information about the associated comorbidities. So in this context, we use high resolution optoacoustic imaging, that means RSOM. As Hailong already shown the high resolution imaging details of this one. This is, you can get the 3-dimensional view of the top skin layer, epidermis, and also to the dermis up to 2 to 3 millimeter high resolution. So next, I will show you the first clinical study. We did it in a National Skin Center. This study is conducted in 100 subjects of eczema of varying severity. The image on top, this is shown from the healthy, mild and moderate severity of eczema. And this is for the non-lesional part of the eczema from the mild subject. As you can see, we derived few imaging metrics such as epidermal thickness, total blood volume, low and high frequency ratio, and vessel diameter. So the frequency band which we are detecting, since our detector has a central frequency of 50 megahertz, we split into 2 frequency band, low and high frequency band. Low frequency band basically indicate the largest structures, and high frequency band represents from the smaller structures. So if you look at this epidermis thickness, it shows a linear increase from the mild to moderate to severe. You can quantitatively track it. Similarly, total blood volume, which is indicating a total vascular network in the dermis region, which also show an increase when you are going from healthy to moderate to severe eczema. LHFR, which is a ratio of low and high frequency signals, which is again shows an increasing trend between healthy region versus mild and moderate eczema conditions. Vessel diameter also indicates an increasing trend, basically between health and mild and moderate case. It shows that a high degree of inflammation in the eczema conditions. So this imaging metrics can be used to form a quantitative index. So what we did is that subsequently we formed a SPM classifier method to classify this healthy and eczematous skin. We could achieve an accuracy of about 87% in sensitivity. Accuracy of 87%, sensitivity of 96%, and specificity of about 83%. Subsequently, we formulated an eczema, vascular, and structural index based on these three metrics, that is epidermal thickness, TBV, and LHFR. And we could follow the severity of eczema very effectively, and this is compared with the SCORAD system, and we could achieve a very high accuracy as well. Next, we use these techniques to look at the treatment response in a subject of suffering from eczema since childhood. This subject is undergone a biologics treatment, and we looked at that vascular changes before and after treatment. Here the image shows before treatment, and this is after treatment. It's very obvious that epidermis thickness is very much reduced after treatment, and other parameters like total blood volume and vessel diameter is also changed. We could see a decrease of about 32% in epidermis thickness post-treatment, and similarly a reduction of 10% for TBV and vessel diameter for 26% after treatment. So this shows that RSOM can be used as a quantitative way to monitor the treatment response. So far, we have been concentrating on the structural change. Now, I'm using this multispectral RSOM to look at which is operating at 4 wavelength and to reduce the functional information. By functional information, I'm referring to the oxygen saturation. So what we did is that our study, this study shows that there is a clear trend in increasing of oxygen saturation when you go from mild to moderate to severe cases. That means as a severity increases, this indicating higher level of oxygen saturation indicates a higher degree of inflammation. Our study also revealed that in the case of severe AD, the difference in the subclinical structural features of the skin between lesional and non-lesional part is indeed very minimal. The difference in the structure features between the lesional and unaffected areas is thought to be mostly by virtue of epidermal barrier dysfunction and less so from the systematic immune response. Now let us move to the psoriasis. Just like in the eczema cases, here also clearly we can observe a clear structural differences, and it is quantified between various severity. This three-dimensional spatial mapping of skin chromophores, including melanin in the green, oxyhemoglobin in red, and deoxyhemoglobin blue, and we can see from left to right, from lesional psoriasis to mild to moderate to severe when you move from left to right. The corresponding maximum intensity projection images clearly show the difference between these three categories. The white arrows indicating the epidermal thickness, which shows a clear trend between mild, moderate, and severe case of psoriasis. Quantitatively, if you look at, just like in the case of eczema, there's an increase in severity is accompanied by an increase in oxygen saturation, SO2 level, both in lesional and non-lesional location. Same trend is observed for total blood volume and epidermal thickness. Though non-lesional skin is less inflamed than the lesional skin in mild case of psoriasis, but it is significantly affected in severe psoriasis cases. Difference between lesional and non-lesional skin is minimal in severe cases. This finding is interesting, which could serve as an early indicator of future disease progression to monitor the future disease progression and its origin, aligning with the previous histopathologic study. Next, we are using the treatment response monitoring again using through the RSOM. Here, a subject with a mild psoriasis underwent treatment using topical steroids and biologics. It illustrates again a reduction in the SO2 value, oxygen saturation value post-treatment in lesional psoriasis skin, where as observed in difference steeper for and non-lesional skin compared to lesional part of the skin. Although statistically non-significant, this reduction aligns with an anticipated inflammation mitigation in the skin post-treatment. Similarly, a quantitative decrease in epidermal thickness is also monitored after treatment. The key point is that these metrics could be used as an objective method to assess the treatment response, which will help clinicians to tailor the treatment and adjust the dosage. Finally, in our ongoing study, we evaluate the structural and functional alteration in the skin microvasculature of patients with diabetes, obesity, and eczema. So basically, we categorize this group of 38 subjects into two categories. That means one is eczema, one is healthy. Then in eczema group, AD group, we again subdivide in two groups, with diabetes and without diabetes. Similarly, so-called healthy group, means non-eczema group, we again into two groups, diabetes and non-diabetic groups. So in this figure on the left side, NDM refers to non-diabetics, DM refers to diabetic mellitus, DM refers to the diabetic mellitus and DM refers to non-diabetic mellitus. NAD refers to non-AD, that means healthy, and AD refers to the eczema AD condition. So when you look at this imaging features, it's very clear that in the non-diabetic and non-AD subjects exhibits a well-defined melanin superficially with a blue tinge of melanin, and blue tinge indicating the deoxygenated hemoglobin. In the DM category, that means diabetics groups, the melanin layer thickens in intensity, indicating proliferation of this basal epidermis. In contrast, the melanin layer is thicker and sparser in AD subject. Additionally, the redder, more highly vascularized dermis observed indicates underlying immune dysfunction, inflammation, and subsequent swelling. Now, the interesting is if you look at the subject with AD and DM, patient with both DM and AD display thickest and sharpest melanin and most vascularized dermis, suggesting a synergy of dermal vascular hyperproliferation, inflammation in DM and AD cohorts. We are analyzing this quantitatively, and this analysis in progress. So this preliminary findings reveals that diabetes and obesity have adverse effect on both dermal microvasculature and epidermal barrier function, with atopic dermatitis exacerbating these effects. This information is also underscoring the potential of RSOM, or high resolution imaging, as a point of care non-invasive tool for assessing skin health in patients with these common comorbidities. We hope that in future, the developed approach and algorithm could be aimed to correlate skin microvasculature and saturation oxygen pattern derived can be used as to correlate the associated diabetes and morbidities to extract disease-specific structural visual features. Finally, to summarize, we developed optoacoustic-based structural and functional imaging tool to approach to differentiate the severity of eczema, psoriasis, and also to monitor the treatment response. We developed a quantitative imaging metrics, a scoring system called EVSI, to look at the severity. We also correlated the microvascular changes in the diabetes and eczema subject, and we could see a correlation and how this is interplaying is affecting in the subjects. So let me summarize and conclude. I will try to thank our team, Translational Biophotonics Lab, headed by Prof. Malini, and our team is a purely interdisciplinary team working on the translation of the imaging and sensing technology for various biomedical applications. Most of this image analysis is done by my colleague shooting, and I would like to thank the entire team for this one. And our clinical partners, headed by Prof. Stephen Thang from National Skin Center, Dr. Yuk Wing, and Dr. Hazelum. Thank you for your attention, and we are ready to take any questions and also to collaborate if there is any synergy in this one. Thank you.
Great, thank you very much, Dinish. Very interesting talk. We have by now many great questions that have been coming in, but just to remind you, if you have any additional questions, you can type those into the question section in the GoTo tool that should be on the screen. And just in case I can't get to all the questions, we'll follow up with people individually afterwards. Good. So then I think the first question, perhaps maybe for Hailong. You showed data on assessment of skin microvasculature in diabetes. how would you say that RSOM compares to other techniques in capillaroscopy is written here in terms of usability and utility for assessing microvasculature?
Yeah, thanks for the question. Yes, I think we have a unique capability to balance between the resolution and the penetration depths. For example, if you compare to the capillaroscopy, for example, to assess the capillaries of the nail region, I mean, we can certainly penetrate deeper. Of course, probably the resolution-wise, we're a little bit less than the optical microscopy. So this means this brings new capability because use of RSOM to assessing the skin microvasculature. As all of the three talks indicate, we can achieve tens of micrometer resolution in the penetration depths of a few millimeters, depending on the wavelengths we're using. These capabilities have not been achieved by other techniques so far, only by RSOM. Yeah.
Okay, great. Thanks so much. The next question I think I'll ask of Sara, and just to remind you or point out you're muted. You showed RSOM data with therapy. How would you think that an RSOM image could affect clinical decision making in what you've talked about? You're muted, Sara.
I think that the RSOM could be more useful to decide when and when change the therapy during the follow-up, and not at the diagnosis, but more during the therapy, to understand if we have to change therapy or to add more topical therapy in the immuno-related disease or in patient affected also by actinic keratosis.
Great, thank you. Next question, I think, this must be for Dinish. Do you think that RSOM tells you something more about response to therapy that can be learned as compared for something standard like clinical assessment or scoring, pointing out the easier score at?
Yeah, so good question. So the point is that by existing technology, we cannot see anything below the skin. Very simple. What clinicians are seeing is, as you see on the superficial from the outside, they cannot get any information, subsurface features. By using RSOM, as we shown in both psoriasis and eczema cases, you can look at changes in the markers, either in the epidermis thickness or blood volume or oxygen saturation. You can have this quantitative way to look at this change that will clearly help the clinician to adjust the dosage. So to answer short, there is not any available non-invasive method to look at it longitudinally other than RSOM at the moment.
Okay, thank you, Dinish. And you mentioned quantification there. I think I'll ask the next question to Hailong, but really anybody can answer on this. But basically, Hailong, you were introduced the technical bit. And the question here is, it's more of a clarification really, but how are you using RSOM to obtain quantitative information? Could you please elaborate?
Yeah, so we, as introduced in my presentation, so we developed this machine learning based algorithm which can automatically quantify the features from the RSOM volume. For example, we separate the layers, like we can compute this epidermis thickness, as Danish or Sara's talk mentioned. So the epidermis thickness is actually an important feature correlated to certain disease, such as the psoriasis. And also we can automatically segment the vasculature features such as the vessel diameter, vessel, length, all the features. And because, for example, in our study in the diabetes, we show that this small vasculature, for example, the vessels in the diameter in the range of less than 40 micron actually has a very strong correlation with the severity of the diabetic complications. So that means suggesting that could be, for example, this impairment from this diabetic complication comes from the small vessel first, and then more impairment compared to large vessels. And overall, this segmentation approach we have actually validated with different existing approach and shows very good accuracy to segment those features. I think, yeah, this is a reliable and automatic computation approach, could enable this quantification or for RSOM analysis.
Okay, thank you. Next then, I'll ask Sara a question, I think. You showed images from animals and humans, and these images look a lot different. Do you think that the biomarkers that have been discussed in this presentation would work on animal data?
In our study, we took the image at the level of the ear of little phantoms. We could study this biomarker taking into account the difference in terms of anatomic characteristic like thickness and vascular pattern of animal.
Okay, good. Dinish, what impact does skin tone have on RSOM imaging?
Yeah, it's very much so. We published a paper a few years back, and now we are working on that one as well. So this melanin is really affect the depth of interrogation. So our previous study and ongoing study we are mainly looking at FP score, Fitzpatrick score up to 3 or early 4. But in the darker skin tone, we are not able to get deeper structures. So there should be definitely a way to improve this one, and we should have a collective efforts to look into this problem. Yeah.
Okay, great. I'll ask one more question and then we'll conclude the webinar. There'll be a few other questions that we can follow up on. So Hailong, how long does data analysis take for manual segmentation versus the kind of deep learning, machine learning processing that you were talking about with the deep RAP?
I mean, this computation speed is actually for the manual ones is really depends, because for the manual ones, normally we need to fine tuning to the specific group of data set. For example, for the thresholding, you need to adjust the thresholding values, and depending on the contrast of the SNR of the data. So this will take time. And with the automatic approach with this model, we can, once we have the model trained, and then the computation is very fast, very straightforward, and also we can get the segmentation and also the feature computation and more reliable. So I think, yeah, this is a big improvement in terms of from the manual segmentation to this automatic computation based on the machine learning process. Yeah.
Okay, thank you. Thank you very much. I'd like to thank all the speakers, and we appreciate all the great talks. And I for one, have really enjoyed this great session with 3 different topics. We'll be in touch over the next few days with the attendees, with the recording, and also we would very highly appreciate if you would take part in a survey request that you receive via email so that we can continue to improve on our webinar offerings. Thank you very much for your time today, and I'll sign off and say goodbye. Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.